Hey, this is Jeremy, and today we're going to be talking about the respiratory center and what controls your respirations. So you have a couple different parts. You have your neural control, you have your chemical control, and then you also have some other factors that we're going to be talking about. So what I mean whenever I say your neural control, that's going to be referring to your neurological system. So in your brainstem, you have this section of your brainstem which is called the medulla and the pons. And in the medulla and the pons, you have a couple different sections that go into actually controlling your respirations. Now, the first section, that's going to be known as your dorsal respiratory group, so or your DRG. So what happens with your dorsal respiratory group is if you're just talking and just breathing like normal, you're just doing your daily activities, your dorsal respiratory group is going to be in effect. Your dorsal respiratory group is what takes care of your regular autonomic or automatic functions. And your ventral respiratory group, that is going to be more in line with your voluntary control. And so what that means is if I told you to take a deep breath and you did take that deep breath and you blew it out, what would happen was in that moment, whenever you took that deep breath, you were stimulating your ventral respiratory group. So you can think of the ventral, it starts with a V, so voluntary starts with a V as well. So ventral for voluntary whenever it comes to your ventral respiratory group. So we also utilize our ventral respiratory group whenever we're singing or whenever we're laughing or we're blowing up a balloon. All of these things are it's something that requires us to be able to have some form of control over our respirations. And that is the really big important part to understand right there. Now you also have these things called effectors. Effectors are essentially the muscles that actually cause respirations to actually happen. So that's going to include your intercostal muscles and your diaphragm. Those are effectors of your respiratory system. And so you can look at it as effect, or it's EFFECTORS. So they're causing an effect to happen. So my brain decides that it wants to breathe. So my muscles, they're going to initiate that response. They cause that effect to happen. So your effectors, those are going to be your muscles of your respirations. Now you also have these things that are known as sensors. So with the sensors, what you have is you have a couple different types. You have your chemoreceptors, you have your mechanicoreceptors, you have your proprioceptors, and you also have your irritant receptors. So your chemoreceptors, what they do is they actually measure the chemical composition of your blood, and they're in the medulla, the carotid bodies, and even the aortic bodies. And so what they do is they measure the chemical composition of the blood. And you also have chemoreceptors that measure the pH of your cerebral spinal fluid. Essentially what they do is they look at the amount of oxygen that you have, the amount of carbon dioxide that you have in your body, and what your acid-base balance is. So is your body's the body's fluid, is it acidotic, is it alkalotic? What is your body's state at that moment in time? And based off of that information, those chemoreceptors are going to send out signals to your respiratory centers of your brain, which we just talked about up in the medulla and the pons. What they're going to do is they're going to say, hey, we need to breathe faster, or we need to breathe slower, or we need to breathe deeper, or we need to breathe a little bit more shallow. And that's the part of what those chemoreceptors do is they look at the chemical makeup and send back information for your body to help regulate that chemical makeup. Now your mechanicoreceptors, those are going to be also known as your stretch receptors. So, and that goes with your Hering-Brewer reflex, which is it essentially prevents you from breathing in too much air and blowing your lungs away, or blowing a hole in your lungs. So what happens is whenever you take a deep breath in, there comes a point where you can no longer take any breaths in. So what happens is these mechanicoreceptors, these stretch receptors, they actually stimulate that reflex, the Hering-Brewer reflex, and they tell you to stop breathing in or else there's going to be damage. whenever we are ventilating somebody with BVM or somebody who's been intubated and they're on a ventilator, those stretch receptors, they don't work anymore. Or if they do work, it's in a very minimal capacity. And what you can't have, or what you need to be careful of, whenever you are ventilating anybody with a BVM, or you have them intubated, or you even have a ventilator, you really only want to give enough of a breath to see that chest rise and fall. Because if you go to, if you over ventilate them with that BVM, what you can do is you can actually pop a lung or cause tissue damage. And that's going to be known as barotrauma. So baro, B-A-R-O, that stands for pressure. So your next receptors, those are going to be your proprioceptors, and they deal with proprioception. And so what proprioception is, that's essentially your awareness of your body's location in the space that you occupy. So you're aware of where your head is, you're aware of where your arms are, your legs, and you're aware of where they fit in the immediate space around you and what you're controlling. And so what these proprioceptors do is they aid in that awareness, and that can be very vital, especially if you have to take a deep breath in and you need to physically shift your body to help facilitate that breath to come in. And that's going to help with the sniffing position, or you find somebody who's in the tripod position. All of those things go into that proprioception, where that patient is very aware of where their body fits in the space that they occupy. Now you also have irritant receptors. Now irritant receptors, they're in the trachea and in the larger airways, so your bronchi, bronchioles. And so what they do is, if you breathe something in, let's say that you breathe in a whole lot of dust or some dust particles, or you're at a fire, you breathe in some ashes. What can happen is if those chemicals or that dust, whatever it is, gets in your trachea or gets in your larger airways, what's going to happen is they're going to sense that irritant, and it knows that it's a foreign body. So what can happen is you can have mucus that is going to go to that location, and it's going to kind of try to isolate that specific irritant. And then we're also going to try to cough it up. That's why if you've ever been drinking something and you try to laugh or inhale at the same exact time, you have fluid that may make it past your epiglottis, that may make it past your larynx or your vocal cords, and they get in your trachea, and then all of a sudden you're stuck there coughing for however long it takes for your body to feel better. And the purpose of that cough is to get that irritant, whatever it is that is irritated your trachea, to get that out of that location, to prevent the opportunities for disease and infection to actually happen. And so now you also have cranial nerves that go into your function of your neural control. So your cranial nerves, the two big ones, are going to be your 9th cranial nerve and your 10th cranial nerve. Your 9th cranial nerve is known as your Glossopharyngeal nerve. So what that means is, if you understand that it's got the pharyngeal at the end, so that's going to refer to your pharynx. So your Glossopharyngeal nerve, it helps innervate the tongue in the pharynx, and it actually helps with stimulating the swallowing reflex, and it can actually help innervate those salivary glands as well. So not only does it help you breathe and swallow and maintain your airway open, it helps produce the saliva that actually allows you to eat your food and allow it to slide down your esophagus in a way that it's not as likely to become an obstruction. Now your vagus nerve, the big thing that we need to know about the vagus nerve as far as it goes to the respiratory center is that it actually carries information to your brain about the stretch receptors to the respiratory centers. So if you start taking that deep breath in, the way that your body sends that information back to your brain through the sensory aspects of the vagus nerve is going to be through that vagus nerve. It carries that information about the stretch receptors back to the brain to know, hey, we need to stop taking that breath in. Now, whenever we get into the chemical control of breathing, What this is going to refer to is the carbon dioxide and the oxygen and the acid-base balance of your blood and your cerebrospinal fluid and your body fluids. So what happens is it's wanting to monitor those chemicals. It's wanting to maintain within a normal range, and it's going to be doing this through the chemoreceptors. So the chemoreceptors, they are very, very acutely aware of the chemical makeup of your body. So what happens is they respond to the chemoreceptors. They're going to respond to changes in the carbon dioxide and the pH in the cerebral spinal fluid. Now, the cerebral spinal fluid is essentially a direct reflection or an indirect reflection of the carbon dioxide levels in arterial blood, as it's very, very easy for carbon dioxide to be able to pass from the CSF to the blood. So what happens is if your body recognizes that you have, and we're going to be referring specifically to the carbon dioxide aspect, what happens is if your body or those chemoreceptors, they recognize that you have an increase in your carbon dioxide in your cerebral spinal fluid, what that means is that my CO2 levels are increased. This means that my arterial blood gases, my arterial CO2 is increased. And this is going to make me acidotic. And so with CO2 being a direct reflection of respiratory effort in a way, what's going to happen is those chemoreceptors, they're going to send off those signals to say, hey, we need to breathe in more. We need to breathe in more oxygen and get rid of this CO2. Now the inverse is also true. If you have your cerebrospinal fluid and those chemoreceptors, they're looking at your blood and they're looking at the carbon dioxide levels and they say, wow, that carbon dioxide is really low. What's going to happen is those chemoreceptors, after monitoring your cerebrospinal fluid, your CSF, they're going to say, hey, we need to slow down our breathing. We need to retain some carbon dioxide. And there's a couple other factors that go into this, and it's not just that cut and dry, but that is essentially what those chemoreceptors do whenever they are looking at your cerebrospinal fluid. They're looking at that carbon dioxide. If it's too high of a carbon dioxide level, they will speed your breathing up to get rid of that CO2. If the CO2 is too low, then what's going to happen is they are going to if your CO2 is low, that means that your oxygen is likely high, so they're going to slow down your breathing so that you are going to retain some of that CO2. Now, there's also this thing called the hypoxic drive. The hypoxic drive in current textbooks, current medicine, it is looked at as a theory, not something that has necessarily been proven. And so what they're looking at with this theory is that if you have somebody who is in end-stage COPD, not all COPD patients, but somebody who is end-stage COPD, their chemoreceptors may not be responding well to the carbon dioxide levels in their cerebrospinal fluid and in their blood. So what the hypoxic drive theory, what it says is that they are operating off of their oxygen levels. So if you have somebody that has too much oxygen, you give somebody too much oxygen, those chemoreceptors, they sense that and they say, oh, we don't need to breathe anymore. We have plenty of oxygen. And so the theory is that you will take off somebody's respiratory drive. But what you need to consider with this is you never want to withhold oxygen from somebody who may potentially need it. An SpO2 or an O2 level of 86% is not acceptable and it's not conducive for life. So what you need to do is never withhold oxygen from any patient. If you feel that they need oxygen and they're struggling to breathe, go ahead and give it to them. Those COPD patients, they are typically going to be short of breath. And don't withhold oxygen just because you think that you're going to take out their hypoxic drive. It is a theory. And should they pass out, then we can always manage their airway accordingly. Now, there's also buffer systems that go into your control of your respirations. So your buffer systems, there's three main ones. So you have circulating bicarbonate, you have your respiratory system, and then you have your renal system, and those are all going to be part of your buffer systems. So your buffer system is essentially a rapid defense mechanism to adjust your pH and your blood and your O2 and your CO2 and maintaining that acid-base balance. Now, buffers are known as substances that can receive or donate hydrogen ions, and that hydrogen ions is really important, especially when it comes to pH, because you can look at pH and it is essentially what it means is the potential for hydrogen, or the measurement of acidity, and hydrogen is an acid. So what happens is, if you have somebody who does have copious amounts of hydrogen ions, what can happen is the bicarbonate that we have floating in our bodies, it's just a chemical that we have in our bodies, it can actually absorb a hydrogen ion. And so whenever it absorbs that hydrogen ion, it's going to be known as carbonic acid. And we also have carbonic acid that's floating through our bodies naturally as well. So what happens is that carbonic acid, it can be utilized and be broken down into CO2 and water based off its chemical makeup. So what happens is that water, we can get rid of water through our kidneys, and that CO2 can be exhaled. However, that hydrogen ion is not as easy to get rid of. So what happens is you can also have your carbonic acid, which can break down into bicarbonate plus a hydrogen ion, and that hydrogen ion can also get utilized in other body functions that is going to result in a drop in your acidity levels. And it's all about maintaining a balance of your pH, and our pH needs to stay between 7.35 and 7.45. Now, your respiratory center, or your respiratory systems, as far as how it can control, it's monitored by those chemoreceptors, and those chemoreceptors are going to say, hey, I don't have enough oxygen, I need to breathe in deeper, I need to breathe in faster, or I have too little oxygen, too much CO2, so I need to be breathing faster, I need to be breathing deeper. If your CO2 levels are increased, you're going to be breathing faster, deeper. If your CO2 levels are decreased, you're going to slow down your breathing to maintain that balance, because again, your chemoreceptors, they're mainly going to focus on that CO2 levels. Now, you also have your renal system. Your renal system is going to refer to your kidneys, and your kidneys can help filter out those hydrogen ions and those other acids. And what it's going to do is it's actually going to help maintain that pH balance by getting rid of those acids through your urine. Or if it needs to retain those acids to maintain your pH, it can do that as well. And it's all about balance. You don't want to have too much CO2. You don't want to have too little CO2. You don't want to have too much oxygen. And we always want to maintain that balance. And that's the big part about the respiratory system. It's all about maintaining the balance of your oxygen and your carbon dioxide, making sure that you're properly utilizing everything, and that if your body is going to compensate for it, for some type of illness or disease that it has those capabilities. We have other components that can go into affecting your respiratory system as well, such as if you have an elevated body temperature, you've been taking stimulants such as cocaine or methamphetamine. If you're in pain or you're emotional, it can be happy or sad. And if you're hypoxic due to pretty much any reason, your respiratory rate is going to increase. So increased respiratory rate can be resulted from hypoxia, pain, emotions, CNS stimulants such as meth or cocaine. And an elevated body temperature can also cause those elevated respiratory rates. A decreased ventilatory rate, you're going to see that with people who are sleeping, the decreased metabolic states, or they're taking CNS depressants such as opiates or pain medications, and even alcohol can be utilized as a CNS depressant, and that can depress your respiratory effort as well. So I know this is a lot of information, but the big things to take away is you have chemoreceptors that monitor your CO2, and they're going to monitor your cerebrospinal fluid for that CO2 levels. You have neurological control, you have chemical control, and you have buffer systems that all go into maintaining balance and allowing us to breathe and maintaining our respiratory effort for us without us ever having to think about it.